Actually, since ma'am is talking about publishing antibiograms, we have come up with a hospital infection control newsletter recently. It has been uploaded on the website, and though it's the 6-monthly edition, it carries the antibiogram of the urology department. So you can just go to the website and check it out. Thank you. So coming to the reading and interpretation of an antibiogram, most of the, some of my slides may be repetitive. Most of the things, in preceding classes have already been covered by by other speakers and teachers. Basically, what is an antibiogram? I am today here going to talk about that how the Department of Microbiology or the antimicrobial susceptibility testing result can help the clinician in administering the correct antibiotic to the patient, right? So basically, what is an antibiogram? An antibiogram is presentation of cumulative antimicrobial susceptibility testing data for a specific pathogenic microorganism or an isolate from a single institution periodically. Though of course multiple institutions can be involved, it can be a regional antibiogram also, but by and large when we talk about hospital based antibiograms, we say that they are cumulative, that is successive isolates have been taken over a certain period of time. It is better to have it biannually, though of course you can publish it annually also, or even 3-monthly or quarterly as well. And it is published periodically, that is at a certain time interval. How do the antibiograms help the clinician? They help to guide the clinician as well as the pharmacist in selecting the best empiric antimicrobial treatment. So what is empiric? Empiric antimicrobial treatment is the antibiotic that you administer to the patient till you get the final and definite culture and susceptibility testing report for that particular isolate which has been recovered from the sample that you have sent. So please understand that this antibiogram gives you a knowledge regarding the local epidemiology or the local pattern of susceptibility over a period of time, and it aids you in starting the empirical antimicrobial agent, right? Till the microbiology report comes after 48 to 72 hours. So I'll just start with, I'll give you a practical example of a case that suppose you have sent a sample to the lab and you get an AST report for a isolate. How are you going to interpret it? So the important part is that how are you going to interpret the antibiotics that have been reported as either susceptible or resistant or maybe intermediate. Okay. So this is an example of a case where there is a classic presentation to the OPD of a 42-year-old female who presents with fever and burning micturition. And she is a classic case of community acquired UTI. And the physician empirically, okay, so because she has symptoms of classical UTI, she's empirically started on ciprofloxacin, which is a quinolone. The urine sample is sent for pus cells and culture. And this is what the microbiology report tells us after 48 hours. After overnight incubation, we know that the organism is Escherichia coli, which is the most common cause of UTI, right? And the susceptibility report after 48 hours gives us these panel of antibiotics, and this is the interpretive criteria. Now, please note that it is written over here as SNR, and there is one term which is SDT. Now, MS is also there in our reports. MS means moderately sensitive. So there is an intermediate category also as well of isolates. This sensitivity testing has been performed by the conventional disk diffusion method. This is not an automated report which is showing you the minimal inhibitory concentration or MIC values. So this is a conventional disk diffusion report, which by and large there is the Kirby-Board disk diffusion method which is recommended and which we follow for rapidly growing isolates and for not very sick patients. The MIC testing is more valuable for blood culture isolates and very sick patients. So now the pathogen is Escherichia coli and the panel of antibiotics is given over here. So let us see that what are the antimicrobial agents. Now beta-lactams are the most common group of drugs that we usually administer. And there are about 10 antibiotics which are nearly 10 which are beta-lactam agents. So as you can see, there is ampicillin, there is aztreonam, and there is cefazolin. Cefazolin is a first generation cephalosporin. All three agents are resistant. Cefepime, a fourth generation cephalosporin, is SDD. Can anybody tell me what is SDD? Huh? Please be louder.
Selective dose dependent?
Susceptible dose. It is not selective. It is susceptible dose dependent. So, the susceptibility of the pathogen depends on the dosing that you administer. So, that is why it is SDD. Susceptibility, that is dose dependent. Then we have two third generation cephalosporins which are ceftazidime and ceftriaxone. There is cefoxidin which is sensitive. Then there are three carbapenems: ertapenem, meropenem and imipenem. All three are sensitive. There is a BL-BLI combination, that is beta-lactamase, beta-lactam, beta-lactamase inhibitor combination. The inhibitor over here is tazobactam. So nearly 10 antimicrobial agents that are related to the beta-lactam group of antibiotics, and most of them are resistant except for the carbapenems. See, what I'm trying to highlight over here is I'm not going to give you a very theoretical aspect of the enzymes or the drugs. But if you have a fairly, basic knowledge regarding the enzymes, then you can understand the mechanism of resistance that is being given and the interpretation, so that you are able to administer the correct drug. So we can see that apart from the carbapenems, most of the beta-lactam agents are resistant, right? Then ciprofloxacin, the quinolone that we have administered empirically, is also resistant. Among the aminoglycosides, we have amikacin, there is gentamicin, and there is tobramycin. So tobramycin and gentamicin are resistant, but amikacin is sensitive. So try to understand that among the same class of antibiotics, there are one or two drugs which are resistant and one or two drugs which are susceptible, right? Cotrimoxazole, another oral agent, is again resistant. Piperacillin tazobactam is susceptible. So I'm not going into the details of what are beta-lactam rings, but we all know that they have a nitrogen containing ring at the core of their structure. And as given in the antibiogram, they can be penicillins, cephalosporins, cefamycins such as cefoxidin. Cefoxidin was susceptible in this E. coli isolate. Monobactam such as aztreonam, and imipenem, meropenem and ertapenem, right? Now what happens when there is the mechanism of drug resistance? Predominantly in gram-negative pathogens, certain enzymes are secreted which deactivate or hydrolyze the beta-lactam structure and then render the antibiotic, the antibacterial activity of the antibiotic does not occur, right? So there are the predominant mechanism among gram-negative pathogens such as E. coli, Klebsiella, Acinetobacter, Pseudomonas are the beta-lactamases. These are enzymes which are going to cause resistance to the antibiotics that we have discussed or represented in the antibiogram. Now just look at this classification. Don't go into the details. There are basically 4 classes of enzymes. These are A, B, C and D. Now our isolate was resistant to the 3rd generation cephalosporins also, as well as ampicillin and the 1st generation cephalosporin. So now when we add the word extended to the beta-lactamases, it means that isolate is going to hydrolyze the 3rd generation cephalosporins as well. So if it is an ESBL producer, it means that it is going to belong to this category of enzymes. And these are the most important nosocomial enzymes, that is CTXM, SHV and TEM. And they will be inhibited by the usual inhibitors which are clavulanate, tazobactam and silbactam. So if it is cefoperazone silbactam, if it is piperacillin tazobactam, and if it is amoxicillin clavulanate, it is going to act on the isolate which is producing an ESBL. So your piperacillin tazobactam or a Magnex is going to work, right? Now coming to the B class of enzymes. B class of enzymes are the metallo-beta-lactamases. Now, our isolate was susceptible to the carbapenems. Metallo-beta-lactamases are those enzymes which are going to, for them the substrate is the carbapenems. So since our isolate was sensitive to the carbapenems, it means it is not producing a metallo-beta-lactamase, right? See, don't think that this is a didactic or a theoretical. You just see the basic ideas. I know that so many classes have been taken previously. But you just have to understand the interpretation of the drug resistance and susceptibility pattern. So if your isolate is susceptible to carbapenems, that means it is not producing metallo-beta-lactamases. Plus, ACE-GONAM will also be susceptible. Then we have the class C enzymes. The class C enzymes are the AMP-C producers. Our isolate was sensitive to cefoxitin. Now, most of the epidemiology in India is such that most of the isolates, at least from the ICU or the hospital associated isolates, are by and large, more than 80% of them produce ESBLs as well as AMP-C together. However, if your antibiogram is telling you that third generation cephalosporin is resistant and cefoxitin is susceptible, that means it is an isolated ESBL producer and AMP-C is not being produced. In addition, if it is sensitive to carbapenems, it means MBL is not being produced, right? The last group of enzymes is class D or OXA group. This is not so prevalent in India, so I will not go with that. Now, just coming back to the interpretation of the antibiogram. So here, what do we have? We have resistance to ampicillin, ACE-GONAM, cefazolin, ceftazidime, and ceftriaxone. So definitely my isolate is a extended spectrum beta-lactamase producer, right? It is susceptible to cefoxitin, so it is not producing AMP-C. It is susceptible to ertapenem, imipenem, and meropenem as well, so it is not producing metallo-beta-lactamase, right? It is resistant to ciprofloxacin. It is resistant to cotrimoxazole. It is resistant to 2 of the aminoglycosides. So I have a multi-drug resistant Escherichia coli isolate that has been acquired in the community setting, and now my empirical antibiotic treatment has to change. Now, sadly, what is the problem? We have very few oral agents now in this antibiogram. I have deliberately omitted fosfomycin. Fosfomycin ideally is a restrictive class of antibiotic. So whatever I have to manage the UTI, I have to manage my UTI with these agents only, by and large. Okay. So till now, I hope I am clear. Do you have any doubts regarding this? So this is how you are supposed to buy and this antibiogram will be true for an E. coli or a Pseudomonas aeruginosa or an Acinetobacter baumannii. By and large, the drugs remain the same, only the activity changes. There are some drugs with anti-pseudomonal activity, there are some drugs which but by and large, these are the panel of agents. Maybe colistin is not here, fosfomycin is not here, and this is for a gram-negative isolate. For a gram-positive isolate, it could be Staphylococcus or Enterococcus. Okay. So, as I told you, the interpretation is that it is an extended spectrum beta-lactamase producer which does not produce AMP-C as well and does not produce metallo-beta-lactamase enzyme. And by sequencing, we later came to know that it was a CTX-M15 producing community acquired E. coli UTI isolate. It was fluoroquinolone resistant. That means that there is a plasmid. It is harboring a multi-drug resistant plasmid which has multiple resistant genes to several classes of antibiotics. Why? MDRO means more than 3 classes of antibiotics have to be resistant. So beta-lactam is resistant, quinolone is resistant, 2 of the aminoglycosides are resistant, cotrimoxazole is resistant. So yes, definitely it is an MDR pathogen, right? And most probably the mechanism of resistance was a plasmid, an extra chromosomal genetic element which can harbor genes to several classes of antibiotics. Okay. So as I told you, the situation in India is grim. In our ICU, in fact, there is nearly more than 95% resistant to third generation cephalosporins and quinolones. Even in the community, there is high percentage of resistance to most of the oral antibiotics. Now there was one term which was known as SDD, that is susceptibility dose dependent. Now what is susceptibility dose dependent? So susceptibility dose dependent is if you give higher dosing or you give more frequent dosing, or you can give extended infusion of the same agent, then an isolate, this is especially important when you have an MIC interpretation of the antibiogram. So there is an isolate for cefepime, this is true. This is also true for fluconazole and candida as well. If you recall, maybe in some previous class you have been told about candida and the susceptibility dose dependent for fluconazole. So if there is a usual isolate for which is sensitive at an MIC value of less than 2 microgram per ml, then the usual dosing is 1 gram every 12 hours. However, if the MIC report gives the SDD value as 4 or 8 microgram per ml, then by increasing the dose or giving it more frequently as extended infusion, we may be able to achieve the antibacterial activity of the drug. So if there is any antibiogram which shows as SDD, then please remember that it only means that you have to increase the dosing, but you have to be sure about the MIC value of the isolate. And it can be extrapolated to certain antimicrobial agents only. It is not true for all drugs. So now with that background, this was a usual microbiology report, which is the dish diffusion testing, and the panel of antibiotics is given there. Now coming across some new beta-lactam, beta-lactamase inhibitor combinations. These are ceftazidime, avibactam. This is being frequently reported, I think. Ceftolozane, tazobactam, meropenem, vaborbactam, and imipenem, relibactam. So these are some of the new inhibitors that have come up. Apart from tazobactam, we have avibactam, vaborbactam, and relibactam. Each of these have been combined with some beta-lactam antibiotic to enhance the activity of the drug or to achieve greater antibacterial killing and overcome the drug resistance that we face when we are using only the beta-lactam antibiotic, right? Now I've already discussed these enzymes before. I've already told you that by and large there are 4 classes of enzymes. I'll not go into the details of that. This was AMP-C, which I mentioned. If it is susceptible to cefoxitin, it means it is not an AMP-C producer. The group A enzymes are the conventional ESBLs, TEM, SHV, CTXM, and KPC, Klebsiella pneumoniae carbapenemase specifically. Then group 2 is the OXA, which is not so prevalent in India, and group B are the metallo or the zinc moiety containing enzymes, which are specially produced by Klebsiella and E. coli in any hospital setting, even Pseudomonas and Acinetobacter, the 4 most common gram-negative pathogens that we encounter, right? So there are those enzymes which hydrolyze imipenem, meropenem, and this is NDM. Can anyone tell me what is NDM? Okay, so it is New Delhi metallo beta-lactamase, right? And it was first isolated in 2009 in some Swedish patient who had traveled to India. There was a urinary isolate of Klebsiella pneumoniae, and it was isolated as back as 2009. However, NDMs are prevalent, highly prevalent in India. So even if you have a new BL-BLI combination, if the prevalence of NDM and metallo enzymes is very high, then you have to be careful about the combination that you are going to choose. So just look carefully at this table. All these, the 4 are newer agents. There are new, inhibitors that are available. However, what are the spectrum of pathogens and enzymes? The Klebsiella pneumoniae, carbapenemases, the New Delhi metallo beta-lactamase. Then there is the OXA type of enzymes. There is carbapenem resistant Pseudomonas aeruginosa, carbapenem resistant Acinetobacter baumannii, and Stenotrophomonas maltophilia. So by and large for E. coli, you have phosphomycin, or Klebsiella, you can have a combination of colistin and carbapenems. What is this table telling us? Look at the reds, no activity. So what is this table telling us? For the New Delhi metallo beta-lactamases, which are very prevalent in India, just see, neither does ceftazidime avibactam work, Neither does tazobactam work, neither does relibactam work or vaborbactam work. So for the West or the US, where the prevalence of KPCs is more, these newer antimicro and where the rates of drug resistance are not so high, you might have a role, and where there are good stewardship programs. Usually they say that if there is more than 20% resistance, we should not be using it in India. But then again, it is so repetitive. It has been told we do not have that choice, that luxury of that choice, that if it is more than 20, we don't use it. We have to use it. There are hardly any choices. So look at the greens. So for the KPCs, then again the KPCs there are the serine and the metallo, which I will not go into the detail, but by and large, for the KPCs, these newer antimicrobial agents may work. These combinations may work. But for the NDMs, they are not going to work. Fosfomycin is an agent which will give you an advantage if your isolate is a New Delhi metalactamase producer, if it is an NDM. But for the carbapenem resistant Pseudomonas aeruginosa, we again have very few choices. For the carbapenem resistant Acinetobacter baumannii, we hardly have any choice. Plasmomycin again is an aminoglycoside, but then again there are several issues involved with it. I will not go into the details of that. So you have to remember which agent has which activity and what are the drugs that we can choose, keeping in mind the local epidemiology or the drug susceptibility report. So I have already highlighted this in the previous slide. I will not repeat it. Tazobactam, you have to remember, will not work against your KPC. This is why I repeated this slide. Please understand that if there is a KPC producer and you want to give a piperacillin tazobactam, please avoid. Please avoid a tazobactam combination if your isolate gram-negative bug is producing KPC. Otherwise, for the conventional beta-lactamases, all the combinations are going to work. For metallo-beta-lactamases, please note, no for across all 4 categories. So, no for the NDMs, for the metallo-beta-lactamase producers. Yes and no. AMP-C, I would say, is not such a big issue. OXA is not such a big issue. But yes, do remember that which combination is going to work for which enzyme. Now coming back to my antibiogram. So there is the traditional antibiogram. Now the susceptibility report which I showed you was for a urinary tract isolate. If suppose I take the successive reports of say 300 isolates of Escherichia coli, positive culture reports, and project the susceptibility data, then I will have a traditional antibiogram or a cumulative antibiogram. I publish it quarterly, biannually, or annually. Then the second type of antibiogram is an enhanced antibiogram. What is an enhanced antibiogram? Enhanced antibiogram is if you collect the susceptibility data for a particular ICU. Suppose I am showing the data for renal transplant recipients or the hematological unit or radiotherapy unit. So an enhanced biogram is a targeted antibiogram which collects the cumulative susceptibility data for a particular facility, and then you know the local epidemiology for the immunosuppressed population, for the transplant recipients, right? Then there are combined regional antibiograms, national, global, or they can be surveillance programs also. Always remember that antibiograms are never made from surveillance cultures. Surveillance cultures are done for infection control programs. Surveillance cultures can, first and foremost, you should not put up the susceptibility for surveillance culture. Suppose I have taken samples from the OT. I have taken surface swabs from some ICU and I am growing say Pseudomonas aeruginosa or Acinetobacter baumannii. Always remember that an antibiogram should never be made from surveillance culture isolates. An antibiogram is always representative of the antimicrobial susceptibility testing results which we obtain from positive cultures of samples that are sent from patients. So there are 2 domains. There is an infection control program under which comes the surveillance cultures which may be taken from the ICU and wards and OTs, and there is a diagnostic category, that is the AST data that is recovered from positive culture isolates, right? So I have given you an example of a gram-negative pathogen. I will just, this is a brief example of a Staphylococcus aureus for which we have the MIC testing data, and as you can see, oxacillin and clindamycin both are resistant. I'm sure all this has been told to you before about inducible resistant and clindamycin associated resistance. So I will not go into that. But by and large, we know that this is a MRSA isolate. It is a methicillin resistant Staphylococcus aureus. So none of the beta lactam agents are going to work, and most probably you have to administer either vancomycin or teicoplanin. Okay. Then what is the other important point to remember? How do we represent the hospital antibiogram or the cumulative susceptibility data? This is the pathogen. The name of the pathogen comes here. The number of isolates have to be written on the column where the name of the pathogen is there. This is how the guidelines recommend. This is not something, you know, which you can represent in your own way. So we have the CLSI, the Clinical Laboratory Standards Institute, which tells us how do we have to project our susceptibility data. And always remember that the numbers over here are percentage susceptible. The most common mistake which is usually made is that because percent is not written over here, we think that it is 60 out of the total number of isolates, or probably 60% of the isolates are resistant. No. If you are looking at a hospital antibiogram, please remember that this always the percentage is susceptible. It is never percent resistant. This is the denominator. The denominator is 300 isolates of Escherichia coli, out of which 60% are sensitive to cefazolin. If I have tested 224 isolates of Klebsiella pneumoniae, then 100% of the isolates are susceptible to meropenem. Please understand this. Please remember this. Otherwise, it will lead to in a hurry, because you see, we don't give so much of time to what we are reading. So we have to understand that this is always percentage susceptible. It is never resistant. And the denominator is the total number of isolates, right? Then, as I've told you, what is the purpose of, and I'll just take 5 more minutes to help clinicians choose initial empiric therapy. Empiric therapy, as I've already told you, before we get the antimicrobial definite susceptibility data from the lab. And if the resistant rate as a general is above 20%, but we don't have this luxury of, 20%. Now, what is the modern workflow of a microbiology lab? Have you all heard of MALDI-TOF? How many of you have heard about MALDI-TOF? Please raise your hands. Okay, so some of you have at least heard about it. MALDI-TOF is a recent diagnostic technique which helps in the rapid identification of microorganisms. So matrix associated laser time of flight mass spectrometry. Okay, so MALDI-TOF, though the cost of the equipment is high, but yes, with this equipment, we have a rapid identification system where even if the blood culture comes positive, we can put up the identification of the pathogen from the blood culture bottle itself without subculturing on the plate. For example, if there is a sick patient in the ICU and you have sent a blood culture and it comes positive within 12 hours, and without subculturing it from the broth, from the bottle, positive bottle itself, I make a smear. I make a smear and it shows me budding yeast-like cells. So I tentatively within 24 hours, I am able to tell you that it is a budding yeast-like isolate. So you know that it is a candidemia. Now, if suppose I am able to tell you whether it is a Candida albicans, if it is a cruci, if it is an auris, within 2 hours of that microscopy report, wouldn't it help you to initiate better treatment, better management of the patient? Or if I see a gram-negative bacilli in my gram stain from the bottle that comes positive, and within 3-4 hours of that microscopy report, I'm able to tell you whether it is a salmonella or it is a acinetobacter. So just imagine the difference it would make to your treatment or management of the patient. So this is how we have managed to decrease the turnaround time of the microbiology report, which previously used to be 3 to 5 days. Just by giving an tentative identification of the isolate, we can institute, and by having a better knowledge of the local antibiogram or susceptibility data, we can initiate better empiric therapy. So if I know that by Malditov it is E. coli, and I know that the susceptibility pattern for E. coli is that by and large it will be susceptible to carbapenems. If it is a blood culture isolate, it will be susceptible to carbapenem, so I'll be able to initiate a carbapenem therapy. If it is a multi-drug resistant Klebsiella, if it has been reported as a Klebsiella, then maybe I'll have to add a colistin to it. So it is all about having good, ID and a knowledge of the local epidemiology or a local antimicrobial, susceptibility data that will help you to initiate correct antimicrobial therapy as well as have a good stewardship program. Okay. So what am I showing over here? Collection and plating of the specimen, of course. Then day one, if you have a MALDI, you can tentatively identify your organism. And then there are the automated susceptibility results, Vitek and Phoenix, which can give you the susceptibility data within 8 hours. Okay, so the turnaround time is much, much less. So what are the 6 basics of antibiogram? Analyze and prepare at least annually. If you are not able to do it 6 monthly, at least you should do it annually. Include only final verified results. Always remember that the minimum number of isolates has to be 30. You only give an antibiogram for a pathogen where the number of isolates is 30. If it is less than 30, please do not plot an antibiogram because it is statistically inaccurate. That is what the guidelines say. So if you are giving an antibiogram, if it's a small place, a small setting, an antibiogram has to be plotted. Then remember that the minimum number of isolates for that isolate or that pathogen have to be 30. Then include only diagnostic, not surveillance. I have already emphasized it before that this antibiogram is not for surveillance cultures. Okay. Then do not include isolates from same patient and always include only the first isolate. What is the biggest problem? Drain pe drain, drain culture pe drain culture. ET aspirate pe ET aspirate. Every second day tracheal aspirate, every second day drain culture. Just tell me, how does it help you to send the tracheal aspirate culture every second day? Every third day you are sending same drain fluid. Every second day you are sending same left PCN, right PCN, left PCN, right PCN. I mean, it is, so difficult to convince the residents as well as the, the consultants that why are you wasting so much of money of the patient? When Monday you send left PCN, Tuesday you send right PCN. Again, Wednesday you send left PCN. One tracheal aspirate, third day again another tracheal aspirate. Left drain, right drain, ye drain, what? How is it? I mean, within 5 days, do you think anything is going to change? And with so much of colonization, you are only treating the colonizers. So please understand, so that is why do not include duplicate isolate. First isolate of the species per patient during the analysis period. Of course, we do have patients with prolonged hospitalization. I do understand that, today it is growing and the flora may change, but that is, that is relevant only to a small subgroup of patients. By and large, the first isolate, the baseline susceptibility data is enough to help you. Drains, tracheal aspirates, ET aspirates, all will give you only colonizers. Swabs will only give you colonizers. So treat the pathogen. Don't treat the colonizer. Don't treat the sample and try to understand for a patient. If you are sending so many culture, it's not true only for bacteriology. TB also I see. 1 sputum, 2 sputum, 1 ball, 2 ball. Every time they do a ball, it comes negative. Again, the patient comes, again they give a ball. I can't understand how many times are you going to do a ball on a patient. But anyways, that is like, what I'm saying is that when you are in the ward, try to understand the value of the test. Okay, it is not that left, right and center you start raising forms. It is not going to help you in any way. Okay. So please understand, duplicate should not be included. Report percentage susceptible. Always remember it is percentage susceptible. It is not resistant. So I've already told you minimum number of isolates have to be 30. There are some isolates that are intrinsically resistant. For example, if we have protist species or some of the UTI causing isolates, remember that there is intrinsic resistance to cephalosporins. Among the gram positive, we know that enterococci are intrinsically resistant to the cephalosporins. Intrinsically resistant agents are not reported for that isolate. I have already discussed the SDD, so I will not take much time. How else does the antibiogram help you? There is an MIC creep phenomenon. This was very important for vancomycin, for the glycopeptides. So what happens when you are plotting the susceptibility data biannually or annually, gradually for your hospital or for your setting, you can see a gradual increase in the MIC values. You know, there is a creep phenomenon. That is, if suppose the MIC value was 0.2 microgram per ml, say during the year 2000, by and large it was near 0.5. Now gradually we are seeing a creep phenomenon and gradually the MIC value is rising. So you know that some mechanism of resistance is being generated and there is a gradual increase in the MIC value, and this has, in fact, it is very significant for MRSA vancomycin. Okay. This is associated with poor clinical outcomes, delayed response, increased mortality. There are many studies on this, that if there is a, this creep phenomenon that has occurred in MRSA, it has led to increased MRSA. There's so much of literature in the West regarding MRSA. In fact, it is the most important pathogen, the gram-positive pathogen that is associated with nosocomial infections. We can also monitor the resistant trends over time. What are the applications of cumulative AST data? Empiric therapy decisions, quality control, hospital antimicrobial stewardship program, infection prevention and control, and others. I'll not go into the details. I've already told you what is an enhanced antibiogram. So it can be sample specific, it can be unit specific, oncology, hematology, or we can even have an enhanced biogram as isolate specific. MRSA, VRE, carbapenem resistant Enterobacteriaceae. Okay. Then what are the few limitations of an antibiogram? MICs are not included. So we do not know actually the specific values for any isolate. They are cumulative. So in the first slide only I told you they are cumulative and they are periodic. Then they do not take into account patient factors such as history of infection or any past antibiotic use. Then the results of single organism antimicrobial combinations do not show trends in cross resistance or synergistic properties of antimicrobials that are used in combination. So thank you so much for your attention. If there are any questions, I can take. Where do you put that? Ma'am, it is only, it's a like a mod. This time we have come up with a newsletter for an infection control newsletter. So only urology antibiogram is there, and we have other articles also of interest. So if you would like to go to the website, you can download the PDF, and the hard copy, the printed version will be available in 1 or 2 days.